Life is unpredictable. Retinal detachments are no different. Post-operatively, some days are good and some other days can be as bad as this, which can cause panic in both the patients as well as the treating surgeons. What do you do in such scenarios? First of all, do not panic. Keep calm and assess the cause. It could be incompletely peeled membranes, intrinsic retinal contracture, proliferation under silicone oil, or presence of a subretinal band. Residual PBR membranes are a common cause of recurrent retinal detachment. So this needs to be removed meticulously. The same can be attempted in an oil-filled eye as shown in this video. And we can make out the retina going back once we relieve the surface traction. And it is always preferable to do an ILM peeling in cases of recurrent retinal detachment just to make sure the posterior pole is free of membranes. Intrinsic retinal contracture sometimes can be the cause for recurrent retinal detachment. Clues to identify the same are subretinal migration of air or enlarging drainage retinotomy. In such scenarios, better to go for a relaxing retinectomy. Area need to be marked with diathermy before cutting the retina, and also it is preferable to excise the residual retina distal to the relaxing retinectomy. Sometimes the intrinsic contracture can be extensive as seen in this case, where a sectoral relaxing retinectomy is not enough. In such scenarios, it is better to go for a 360-degree retinectomy, and the same can be assisted by using PFCL followed by endolaser. This is the post-op picture of the same patient. Rolled edges of the break can be the culprit in case of recurrent retinal detachment, and it is better to freshen up the edges as shown in this video. Sometimes we need to search for the cause under the retina. As you can observe in this case, a long subretinal band inferiorly resulting in recurrent retinal detachment. Such a suspicious subretinal band or membrane needs to be removed meticulously. Oil can also migrate subretinally, and the same can be removed by making a relaxing retinotomy in a saline-filled eye over the area of subretinal oil. Once it is done, as you can see in this case, the oil comes into the vitreous cavity. Sometimes recurrent tractional detachments due to incompletely peeled membranes can have rhegmatogenous component. Presence of break should be suspected if subretinal fluid is disproportionately more compared to the tractional component. Membranes can be mobilized under oil followed by oil removal. Mobilized membrane should be carefully dissected off from the retinal surface. Break was noted underneath during membrane removal.
There could be membranes with retinoretinal adhesion, as we can see along the inferior arcade. Break can be noted at the distal end of the inferior arcade. Rest of the membrane should be removed with meticulous dissection. As mentioned earlier, it's always better to peel internal limiting membrane in such scenarios. In this particular case, the margin of the ole appeared stiff, possibly due to intrinsic contracture. It's better to freshen up the edges by sacrificing some retinal tissue in such scenarios, followed by fluid air exchange and endolaser.
Whenever there is a recurrent retinal detachment, relax, reassess, and ascertain the causes of redetachment. Do a meticulous membrane dissection, achieve hemostasis, and use cryotherapy or diathermy judiciously. Last but not the least, timely intervention helps in handling such cases better.